organizers. A very good morning and a warm welcome to everyone who's joining us online. First, before we go on to start the CME, let's have a look at the corporate video for the National Institutes of Health.
Established in 1998 and formerly known as Clinical Research Center, the Institute of Clinical Research, or ICR, is one of 6 research institutes under the National Institute of Health, Ministry of Health, Malaysia. From humble beginnings, the institute witnessed growth and expansion over the years and now comprises of 5 centers and a network of 36 branches in major hospitals across the nation, including periphery in Sabah and Sarawak. Strategically located within the National Institute of Health's headquarters in Setia Alam, ICR comprises a welcoming, modern, multifaceted structure with shared state-of-the-art facilities. With a deeply rooted mission to improve patients' health outcomes through ethical and quality clinical research, ICR positions itself as an institute that provides patients access to leading research in medical and surgical fields.
As a national institute, ICR's primary core role is driven by critical strategic, interrelated functions such as providing leadership in development of clinical research capacity.
Establishing and maintaining clinical database has additionally been an imperative and ongoing functions for the institute as they continue to deliver for the Ministry of Health.
Attributes of CRC Hospital is that there are different specialties of research within each of CRC. For example, CRC Sarawak is renowned for its cardiology research, CRC Ampang for its hematology research, and CRC Sultanah Bahiyah for their hepatology related research.
As part of their objective to provide ethical and quality research, ICR takes pride in coordinating the conduct of industry-sponsored research, while additionally promoting the conduct of investigator-initiated research.
The Institute continuously establishes collaboration with local, regional and international research organizations in the pursuit of excellence in clinical research for the country. Through these collaborations, the Institute for Clinical Research is also able to facilitate the establishment of hospital clinical research centers. These interrelated core functions go on to fundamentally converge into one overarching principle, that is to provide research that matters for patients.
The Institute of Clinical Research essentially operates under different areas of expertise: clinical trials, bioavailability and bioequivalence study, BABE, clinical epidemiology, national healthcare surveys, digital health research and innovation. More importantly, the scope of research is not only confined to these specific areas. The Institute acts as a platform that provides an entire ecosystem of clinical research for medical professionals and academia in Malaysia, both public and private. Together with its unique attribute of being a civil, service-driven institute, ICR is poised to become a leading clinical research institution in Asia. As ICR continues to lead nationally, the institute is also no stranger to making its mark in the global healthcare and medical industry. Through its clinical research and trials, Malaysia has become the first country in the world to provide affordable tablet treatment for hepatitis C. As the institute further solidifies its commitment in translating medical innovation into the very essence of its motto, providing research that matters for patients. Built upon a strong foundation and strategic functions to providing leading research in medical and surgical fields, the path is set for ICR to continue creating global impact and become a leading clinical research institution in the face of Asia.
Back. My name is Yvonne Lim. I'm with the Institute for Clinical Research, NIH. Today here we we will be talking about the SMART AF study, which looks at the effectiveness of a smartphone electrocardiogram for the purpose of detecting atrial fibrillation after an ischemic event in the brain. So with me here are two of the instrumental people from the study. We have here Dr. Alan Fong, to my right here, who is the head of the Clinical Research Center, Hospital Umum Sarawak. He is also a cardiologist at the Sarawak Heart Center. He has broad research interest in cardiovascular medicine and clinical pharmacology. He advocates modern diagnostics together with precision therapeutics to deliver personalized care to patients. And our speaker of today is Dr. Diana Fu, who is a senior cardiology researcher with the CRC Hospital Umum Sarawak, part of the team for SMART AF. She focuses her work on early detection of cardiovascular diseases. She currently leads projects on digital technologies in both the prevention and management of cardiovascular diseases. Before we start, I would like to inform that for us to record attendances from NIH, there is a link to my cursus at the YouTube description at the bottom. There is also a link to attendance if you're attending from outside of the NIH. And if you have questions that you'd like to pose to our speakers here, there is a link for you to put down your questions. And with this, I will hand over to Dr. Diana Fu to start on her CME.
All right, thank you very much, Yvonne. Yeah, good morning, everyone. My name is Diana. I'm from CRC Sarawak General Hospital. It is my great pleasure to present to you our study which we have published evaluating the smartphone ECG in our cryptogenic stroke patients to detect atrial fibrillation. Stroke due to atrial fibrillation, or AF, is frequently devastating and is often associated with higher risk for mortality and disability. If we compare Asians versus the Americans, Asians with stroke are typically younger, regardless whether the stroke is AF or non-AF related. Stroke due to AF is common, 1 in 6 in the Caucasians or 1 in 5 locally. But these are the patients who are known to have AF or who had AF detected on admissions. Our major concern here is the remaining 5 in 6 or 4 in 5 stroke patients who are not attributed to AF, because these are the patients who presented with sinus rhythm on admission, but they might have atrial fibrillation, which is otherwise paroxysmal, clinically silent, and therefore undetected. Hence, if we could pick up AF in any of these 5 in 6 or 4 in 5 population and change their treatment from antiplatelets to oral anticoagulant, then a secondary stroke is preventable. And to do this, the current guidelines recommended at least 24 or at least 72 hours of monitoring using the implantable cardiac monitors, Holters, or cardiac telemetries. Implantable cardiac monitors represent the gold standard due to their long-term continuous nature in cardiac monitoring. This is supported by evidence presented in the benchmark Crystal AF trial. However, the application of these monitoring strategy raised certain concerns, especially in the local settings. First, the cost of the device itself and the implantation in the patients or the government-funded healthcare systems. Excuse me, the slides are missing.
So while we are addressing the minor technical glitch that we have here, I have a question from the audience. There's a question from Mr. Yu. What is the suggested treatment for cerebral ischemic attacks to prevent atrial fibrillation? A subsequent, if I may rephrase, so he's asking, Oh, so we are back here. So should
Okay,
we
so we just
leave the
continue on.
questions to
Yeah.
the end? Yeah.
So back to our earlier presentation. Now, the first thing with the first concern with the implantable cardiac monitors is the cost of the device itself and the implantation procedures, which is often very expensive and it may burden the patients and government-funded healthcare systems. And therefore, the comprehensive assessment is required to justify these stroke patients for implantable cardiac monitors. The comprehensive assessment procedures may take time, sometimes more than 6 months, especially in settings where competing needs for limiting resources typically occur. This may delay the diagnosis of AF, and in between, the second stroke event may have occurred. Besides that, we should also take into consideration patients' preference barrier to invasive procedures. The Holters and cardiac telemetries, on the other hand, are the most widely used non-invasive continuous cardiac monitors supported by extensive evidence. But again, the access is limited. The Holters and cardiac telemetries are not readily available for immediate inpatient monitoring. And besides that, the reliance on wired external leads may cause inconvenience in ambulation and discomfort to patients. Patients cannot shower or bathe while they are wearing these Holters or cardiac monitors. And therefore, in 2017, we took a step further to evaluate the use of smartphone trial as an investigator-initiated, MRG grant-funded, randomized controlled open-label multicenter trial with one-on-one randomization either into the intervention group with 30-day cardiac mobile or control group with a 24-hour Holter. The Align Core Cardiac Mobile that we use in our trial is a pocket-sized mobile device which is used together with the smartphone app. It has a reported 98.5% of the sensitivity and 91.4% of the specificity in detecting atrial fibrillation. All patients who are enrolled into the Smart AF trial had at least a 12-lead ECG and a 24-hour Holter that showed sinus rhythm. Patients who were assigned into the intervention group had received the smartphone cardiac mobile and had performed patient-initiated monitoring intermittently 3 times a day, each time 30 seconds recording, and during symptoms of palpitation for a period of 30 days. All ECG data were transmitted wirelessly to a web-based archive and were adjudicated by an electrophysiologist blinded to patient's clinical condition. On the other hand, patients who were assigned into the control group had a standard repeat of 24-hour Holter. The patients that were enrolled into our study were aged 55 years and above, had ischemic stroke or TIA within the 12 months prior to the randomization, and had no documented AF by history or during admission. Before randomization, the following tests were minimally required, including the 12-lead ECG, 24-hour ambulatory Holter or telemetry, brain CT or MRI, and transthoracic echo. The outcomes that were assessed in our trial included detection of 1 or more episodes of AF of 30 seconds and above within the 3 months after randomization, effect on treatment with anticoagulation therapy at 3 months, and performance of cardiac mobile. A total of 236 patients were enrolled and randomized. 128 were assigned into the intervention group, 23 were excluded for the reasons specified, and 105 were included into the final analysis. 108 were assigned into the control arm with the 24-hour Holter, 10 were excluded, and 95 were included into the final analysis. As expected, our stroke patients were younger. The baseline characteristics were largely similar between the both groups. Most of our patients had ischemic stroke as the index event. EF were normal, and the left atrial size were normal. Ladies and gentlemen, the 30-day cardiac mobile strategy was superior compared to the 24-hour standard Holter. with a 9.5% detection rate recorded in the intervention group compared to 2.0% in the control group, for an absolute difference of 7.5%. The numbers needed to screen was 13, duration from randomization to detations. 83.7% were classified as normal. On average, half of the patients received at least one notification for possible AF. And of 218 ECGs that were classified as possible AF, 24.8% were determined to be true positive for AF. The proportion of the non-interpretable ECGs remained the same across the monitoring period. And the adherence to smartphone ECG recording 3 times a day for 30 days was only 63.3%, with a significant decline in the adherence from 79.1% on the first week to 52.3% on the 4th week. 70% of the true AF were detected on the first 2 weeks of the monitoring. The experts addressed the limitations the guidelines recommended technologies have with prolonged cardiac monitoring to detect atrial fibrillation in the stroke patients. In 2014, concurrent with the publication of the Crystal AF trial, the Embrace trial was also published on the Journal of New England Journal of Medicine, evaluating the use of external loop recorder, which is worn as a belt around the chest in comparison to the standard 24-hour Holter. The subsequent trial design has evolved to evaluate the indications of these novel technologies for prolonged cardiac monitoring in this high-risk population. The European guidelines had acknowledged the validation of various wireless portable devices for prolonged cardiac monitoring to detect atrial fibrillation. And lately, in Asia, the mobile and digital technologies have emerged as a novel ECG monitoring modalities to screen for paroxysmal atrial fibrillation in the community-based and the population-based study to address our knowledge gap on the epidemiology of AF in this region. A year after our SMART AF trial was published, the SMART AF was cited in a Heart Rhythm Society white paper on the clinical utilization of digital health technology. The findings from our SMART AF trial support the use of mobile technology with advanced machine learning techniques to improve AF detection. The SMART AF trial was one of the first investigator-initiated randomized controlled trial in Asia to utilize the mobile technology to screen for atrial fibrillation in the stroke patients. The study reported 9.5% detection rate, and 24.8% of the possible AF ECGs were determined to be true positive for atrial fibrillation. This has cut down the processes significantly. Instead of having to look into all the ECGs of all 105 patients, the clinicians only have to look into possible AF to verify for the true positive. However, we should also be concerned with the 63.3% compliance to monitoring. This study attributed the reduction in the compliance of monitoring to the increased burden of monitoring. As you know, we need to, the 3 times recording is required every day for 30 days, each time with a 30 seconds recording. This could be a burden, especially for outpatient and patient-initiated monitoring. Besides that, the neurological deficit and smartphone compatibility, digital literacy are another factors which contributed to the reduced compliance to the monitoring. From the SMART AF trial, we have further evaluated the patch device technologies for prolonged cardiac monitoring in our stroke patients in remote monitoring, And we look forward to share with you more reports on these emerging technologies in the future. To conclude, with guidelines recommended Holter technology, we detected AF in 1 in 5 recommended Holter, which is often limited only to 24-hour monitoring practically. We detected another less than 1 patient with AF. But with smartphone ECG, we pick up another 1 patient with atrial fibrillation. With that, I thank you.
Thank you for your brilliant, engaging talk on this mobile ECG device in increasing the detection yield for AF in a patient after stroke. So this RCT is indeed timely in the age where we expect wearables and apps to support remote detection or monitoring of patients with cardiac conditions. So let's have a look at the questions that we're getting online from the audience. So I have a question here from Mohammed Nazirul. He's asking, what is the sensitivity and specificity of this ECG mobile device in detecting other cardiac conditions such as MI and atrioventricular block?
I'll take that.
Yeah.
Yeah, thank you very much. It's a very interesting question. So it depends on the technology that's available. So for example, the cardiac protocols have allowed it to detect atrial fibrillation, which is an FDA certified protocol. And they also have a protocol that does for long QT intervals, corrected QT intervals. So to detect arrhythmia post-MI and AV block, these are still in progress, and I'm sure more research is required to do validation for remote monitoring devices in these conditions.
So how about the sensitivity and specificity in the detection of AF itself? I know it's not the aim of your study here, but do we know the sensitivity and it's around?
Yes, the CardioMobile has a reported sensitivity of 98.5%.
That's very good.
And specificity of 91.4% in detecting AF.
So, okay, let's look at our next question from Dr. Patrick here. So, adherence to the monitoring, as we know, might be a challenge because the patient has to measure their ECG 3 times a day on a daily basis, 30 seconds each time. So, do you have any recommendations or a strategy to improve the adherence, say, if another researcher were to conduct a similar study in future?
This is the reason why we are actually exploring other new technologies like the patch monitoring strategies.
Yes.
The patch monitoring strategies, because not only in smart AF, in fact, in many other trials in overseas, the adherence is always an issue, especially with the outpatient on-demand monitoring. Yeah, because it has to be initiated by the patients itself. So this is always an issue. Yeah.
Right.
If I may add to
course.
this point, and in the smart AF study, the compliance to the protocol actually reduced over time. And that is not surprising. But like Diana has mentioned, this is something that is common towards all diagnostic devices post-event. But let me be very clear. This study is about patients with stroke. So if you had a stroke and you have survived the stroke and in hospital, the most important thing is to try and not get another one. Because the subsequent stroke, if you're not already permanently disabled, the next one could have more devastating consequences, not just from the point of mortality risk, but also for morbidity risk. So in Malaysia, it was published in 2019, there were only 107 neurologists, and that equates to 1 neurologist looking after approximately 300,000 Malaysian doctors, a citizen. So for that, efforts have been made to increase the number of specialists in neurology so that patients with stroke can be more efficiently managed. For those that have already had a stroke, it is important not to get another one. And atrial fibrillation is a known risk factor for stroke. And that was actually the basis of this study, because Sarawak General Hospital, where we operate from, is the main tertiary referral center for Sarawak. And for that, we have to look after a lot of patients, and the most important thing is for those patients who are treated for stroke at Sarawak General Hospital, we try our very best to detect any risk factors which we can therefore identify and treat so that it reduces the risk of the subsequent stroke. Where the SMART AF study is important is because the detection of atrial fibrillation in patients not previously known to have atrial fibrillation allows us to change the treatment regimen. For patients admitted with a stroke in sinus rhythm, they are prescribed antiplatelet therapy. However, if atrial fibrillation is detected, then the treatment change is from antiplatelet to anticoagulation therapy. And as we all know, anticoagulation therapy is the gold standard for managing patients with ischemic stroke to reduce the onset or the incidence of subsequent stroke. And therefore, the SMART AF study clearly demonstrates that the use of a new strategy, i.e. using the cardiac protocol that we undertook and published, is superior to the conventional protocol of wearing a 24-hour Holter system. In Malaysia, it's not very practical to wear a Holter monitor for long periods of time because it doesn't allow you to shower, it doesn't allow you to do other easy, normal day-to-day ADL activities of daily living, compared to something that is mobile, easily used, such as the live core cardia and other medical grade ECG recording devices. So for this, the cardia has been very useful, and because it was available early to the population, we elected to use this technology as a comparator to the pre-existing 24-hour Holter for the detection of atrial fibrillation post-stroke. So that is just to cover the rationale of this particular study, which we believe will change practice particularly in developing countries. And that is why our paper, which is funded by a major research grant by the NIH, is now cited at the Heart Rhythm Society white paper for the use of mobile devices in detection of atrial fibrillation. Thank you.
And on that same note, I would like to congratulate Dr. Ellen Fong and Dr. Diana Fu for your publication of this piece of work in the Europace Journal in 2021. And if I may ask a questions about the methodology of this study. So I'm actually intrigued by the false positive rate of this study, in which I believe the device itself, together with the app, flags the ECGs which were indicative of atrial fibrillation, but at the same time, about 3/4 of them are actually false positives, meaning that they are not true AFs, which need to be adjudicated by in the study it's an electrophysiologist. So in practice itself, how would we go about this? Because there's a need to go through each of these flagged ECGs to determine whether they're truly or not an episode for atrial fibrillation.
This is a very interesting point, and I think very relevant. Like all medical screening tools, which are medical grade FDA certified or CE certified, it is an initial tool to elect to try and screen out patients who actually have the condition or not. A higher false positive rate is not a bad thing. It's similar to if you're trying to board an aircraft. You have to go through a metal detector. Okay. And the metal detector beeps. It suggests that you have something metal that you are wearing. And then you go for a more comprehensive check to see whether you're carrying a dangerous weapon, for example. So this is a similar thing. So whenever it beeps, it might be just a clip, or it may be a buckle, or it's nothing sinister, but there is a screening process that allows this to happen. The alternative is to do a physical check for every passenger that goes to an aircraft, and that makes it less efficient. So having a technology with a higher false positive rate is not a bad thing. Second, atrial fibrillation, as it is as defined by the medical textbooks, eventually has to be done together with a 12-lead ECG traditionally. So the false positive highlighted by Yvonne for the Alive Cardia also mandates a medical person, a medically trained person like a medical doctor, to actually make the diagnosis, because that requires eventually a prescription of a medicine, a change of therapy that a medical doctor is licensed to provide. So it's not a bad thing to have a false positive rate when you can intervene. And that is the advantage of having these new technologies. But in light of the study, because it is it's a trial that requires many patients to be recruited, we are very proud to actually announce that this study was a multi-center study. It's a study involving not just Sarawak General Hospital, but other hospitals in Sarawak, for example, Hospital Sibu and Miri, which are hospitals very far away from us. So in this landmark study, with a major research grant for research, we were able to support and undertake this research in many centers across Sarawak, which is, as you know, is a very large region of Malaysia. And to be able to pull this together with the Clinical Research Center at Sarawak General Hospital, I must personally commend the PI of this study, my colleague Dr. Koh Keng Tat, who is a consultant electrophysiologist at Sarawak Heart Center, as this particular study was conceived at a time he was still training as a cardiology fellow. But that didn't limit him, because as an internal medicine specialist, having served in the district hospital in Miri, has enabled us to actually bridge the gap. To see that the challenges in smaller hospitals and larger hospitals have to be closed, have to be narrowed. And the only way that we can improve the care of patients, improve detection and treatment of patients, is the adoption of these digital technologies, so we can better manage our patients in the clinical frontline. And that is no surprise why the digital health research unit is part of the Institute of Clinical Research, and will continue to work in this environment to generate the kind of data that's going to be relevant to our patients here in Malaysia. Thank you.
And just to add on, in fact, from this trial itself, the CardioMobile has already excluded most normal ECGs. The 3/4 actually comes from the 3.2%, which is a very small percentage of the overall 6,000 ECGs, over 6,000 ECGs who are classified as a true positive. So if we look at this from the workload, for example, like Dr. Kaur himself, during the time of this trial, he was the only electrophysiologist who adjudicate all these ECGs, and he was blinded to all these the patient's condition. Imagine Dr. Kaur alone has to look at all the 6,000 ECGs.
So now we've narrowed it down to
Correct.
about 300.
We narrowed it down to actually just 208 ECGs.
There you go. So it's efficient and
Yes.
and cost and time saving as well,
Yes.
in terms of manpower
Yeah.
to look at each of these ECGs.
Yeah.
So coming back to what Dr. Helen has just said, the key to these technologies and the evaluation of them is the adoption of it. So now we have a question from Dr. Amy here. I'm just going to read her questions. So given the superiority of this technology in detecting new EAF, how do you foresee this technology to be implemented in clinical practice? Is it already underway, or are there further efforts to make this part of clinical practice?
Yeah, so for clinical practice, for example, like in our center, the patient who is able to acquire or obtain this device actually has this option of doing so, because to be able to provide a portable device for every patient at the moment is a little bit beyond this. However, there are other opportunities for patients to actually obtain the cardiac device to actually detect this atrial fibrillation. But what has been clear is that whatever we do has to supersede what is already existing available of the Holter, the 24-hour Holter. On this basis, we are trying to look at other methods of doing extended ECG monitoring in patients with stroke. And that is why there is a second study, again an MRG-funded study, to look at a patch monitor as an alternative to the Cardia Mobile, to the AliveCall Cardia system, where you have to do this protocol that we have published to detect atrial fibrillation. So in summary, in some centers in Malaysia, this strategy has already been adopted, but not yet universally available.
I'm glad to hear that it's already started in some sites. Well, it's a start, and then we have to always start somewhere. Yeah.
And if I may add, actually in overseas, for
Yes.
example, in Australia, they are facing quite similar problems with logistics as well.
Indeed.
So they had a different, in some centers in Australia, they already started a different strategy.
Yeah.
So the alive call was actually performed by the nurses themselves while taking the vital signs every periodically for the patients who are admitted for stroke. So while taking the vital signs, they will perform the alive call ECG on the stroke patients. So this perhaps can be considered in the future as well.
Right, that's good. Taking it a step forward to start monitoring from the point of inpatient admission itself. Good. And so I have a question. In the spirit of generalizability of all the studies that we do, so because it's a recurring theme. Whenever we do a study, we are asked how generalizable is the findings of this study. So in your study, you're looking in patients aged 55 years and above. I believe you do have a reason why you set that as your inclusion criteria. But at the same time, we are looking into technology, mobile applications, which are presumably more easy or more adopted by people who are younger or patients who are younger. Would it be an option to expand the use of these devices in patients who are at a younger age, as some of your cohort studies and the trials that you have shown in your presentation just now?
It's a very good question. I mean, from the clinical frontline perspective, the most important thing is the disease condition. So if we're looking at atrial fibrillation is a condition that the incident rate increases as you get older.
Indeed.
So if to utilize this at the younger age group, it's not unreasonable to, but more research have to be done. So the risk of atrial fibrillation increases when you're older and have other comorbidities such as hypertension and dyslipidemia and diabetes. So the older age group is where we try and obtain this data in this group of patients with stroke. So when they have young patients with stroke, then other investigations also have to be done to exclude other secondary causes, rather than just one attributed to atrial fibrillation and non-valvular AF.
Okay, and I have one last question myself. I think after this, many would agree with us that the benefits of using emerging technologies, whether in the form of wearables or mobile devices that we do not wear, but as a carried around device, can be used to support the delivery of clinical care away from a healthcare setting. So bringing the care closer to the people themselves rather than just restricting it to a clinic or a hospital. And in that sense, we are also supportive and would like to inspire more researchers to look into other variables, or not just in cardiovascular diseases, but also other diseases like epilepsy, let's say. So what is your advice if a researcher wants to embark on a similar study, be it a clinical trial or a cohort study, in evaluating a new device for the purpose of making it more convenient for a patient to be diagnosed or monitored for their condition?
Yeah, this is a really great question. Actually, the first thing is to look at the condition that you actually want to diagnose. Yeah, and that condition is directly related to the burden of the disease, either by the severity or by the number of patients that is going to affect our healthcare system and or our social economic issue. So this is the starting point. So for me, that is the most important question. The second question is to see whether you want to implement it in the primary care setting or in the hospital setting. And mainly for the clinical research center, because there's a network of 37 hospital CRCs. A very good opportunity exists for us within the network to undertake a multi-center study looking at diseases that actually burden the hospital setting within our Ministry of Health and in Malaysia. Third, for this digital health arena, it is actually a blessing, if you can consider a blessing, coming up after the COVID-19 pandemic. What the COVID-19 pandemic has done for us is to increase the health literacy of our population significantly. Yeah. More and more people in Malaysia are aware of how to use a mobile app. Prior to the COVID-19 pandemic, many of my elderly relatives did not know how to use a mobile app. But because of COVID-19, an app such as My Sejahtera, it is now a step further in terms of how we can utilize this opportunity, leverage on the health literacy of the population so they can help to manage any disease condition that we would like to improve the care delivery for in our healthcare system. So for any researcher that wants to look into these avenues, I think the starting point is the disease condition. What is the technology available to us? It may be of a hardware in terms of origin or a software in terms of origin, but how it can be done and to leverage on whichever area that they feel that their research interests are at, either primary care or secondary care. As you might realize, the Institute for Clinical Research, together with its collaborators, won a very big award last year at the National Innovation Summit and a runner-up prize at the Prime Minister's Award, and to develop a cough app. This is something that is a screening process to detect COVID-19 even without an RTK antigen kit. And this is something that we are very proud to leverage on the health literacy and the interest from other supporting faculties or other specialties, such as those in IT, those in biomedical engineering, and all the other subspecialties who historically find it very hard to bridge into the medical arena. But because of COVID-19, we should and must leverage on this so that we can access and improve care of our patients across the country, not just patients who are in the urban setting, but those patients who are in the rural settings, that be able to use app technologies and IT-related technologies to deliver better care for them. And of course, in their own languages even. Thank you very much.
Excellent points there from Dr. Allen. Before we wrap up this session, I've just received one question here from Nicholas, who would like to know about the cost difference and the cost effectiveness of using this mobile ECG compared to the 24-hour Holter. So do you have any information on the cost effectiveness of this device
Yeah, there was no publication in Malaysia on this particular area yet, and we will welcome anyone who's interested to help us generate this cost effectiveness analysis. However, the important thing is the pragmatic use of this. If you were to use a cost effectiveness model, we must compare similar type technology. But these are two very differing strategies. Remember, the Holter, which is the historical way of detecting AF post-stroke, is something that you wear. You can't take this off for 24 hours at the very least. And you just imagine you have a Walkman kind of device, which is linked to your chest on 3 or 4 leads, and you can't take it off for that. The alternative, like as in our publication, in our trial, is something that is wireless, no wires. It is a device, it's a very small device, about this size, and then you put your fingers on it to capture the technology. So to do a cost-effective study would be very exciting, I believe, but in terms of the implications, for the science perspective, comparing two different strategies in terms of how we detect AF post-stroke.
Thank you. And with that, we are coming to the end of our CME session. We would like to announce that there will be upcoming CMEs organized by the National Institutes of Health. So do stay tuned for it. Once again, thank you everyone for tuning in. Thank you as well to our guest speakers here and to the organizers of the CME. Have a great day ahead of you.
Thank you very much, Yvonne. Terima kasih. Have a good day.
Thank you, Yvonne.